Welcome to the Birth Launch Podcast, an empowering space for expecting and new parents to hear candid conversations with experts and learn how to craft your ideal birth. We will tackle the scary and weird questions that come up along the way and provide answers that are driven by science and evidence-based recommendations. I'm going to show you how to redefine parenthood and choose what's best aligned for you and your goals. With 10 years of experience in family education and a master's degree in human development and family studies, I'm ready to help you navigate pregnancy and explore your birth options to free yourself of fear surrounding childbirth. My goal is to help you have an informed and confident labor experience, plus an empowered and joyous postpartum. Hey, Alease, welcome to the show.
Hi, I'm super happy to be here. Thanks so much for having me.
I'm so excited for this topic. So typically when I have people on the show, I know about the topic that we're talking about. Usually I know about it deeply or I just have like some shallow knowledge, but very rarely do I have somebody on the show where I know absolutely nothing. And you, my friend, are one of those people, and this is one of those topics, and I could not be more excited for this conversation. Fertility is something that our team has just started to support. And when we were thrown into this world of IVF and fertility and infertility, I realized like, wow, there is an entire portion of our bodies and our existence that we know nothing about. So this conversation is going to be a first for many of our listeners. It's a first for me. So let's just like kind of dive right in. As an embryologist, what do you do?
Yeah, that's a great place to start. So, as an embryologist, we are responsible for all things IVF lab. So, we are kind of behind the scenes. We are the ones that, if you've done any sort of fertility treatment, you probably don't know who we are. We're the ones that may talk to you every now and then, before your retrieval or when you're getting your embryo report, that sort of thing. So, we are responsible for, you know, growing and creating and preserving patients' embryos. So we do egg retrievals, we freeze embryos, we warm embryos, we do embryo transfers, we do inseminations, we do all of that sort of stuff kind of in the lab.
You are the actual people behind the magic. Everyone's kind of important, but you've got the real secret sauce here.
Yeah, we literally make the babies. Like, I have made babies with my two hands. It's crazy.
That is wild. Okay, so today we're talking about fertility, but specifically anovulation, which is different than amenorrhea, which is not having a period. Today we're talking about actually not ovulating, which obviously, as it sounds, can pose some problems with our fertility. But can you kind of define what is anovulation and then also what causes it?
Yeah, so anovulation is when you are not ovulating. And like you're saying, you have to ovulate to get pregnant. If you are not ovulating, you're not going to get pregnant. And there can be a wide range of reasons why someone isn't ovulating. And part of the diagnostic process is hopefully trying to figure out why. It could be from things like PCOS or endometriosis, hormone imbalances. It could be like a physical issue, meaning that you may not have an ovary. And so maybe you're only ovulating from one side. And so you have anovulatory cycles here and there. So it can be a very wide range, but those are kind of the first things that we think about when a patient is coming in and having ovulation issues.
Yeah, you're truly not releasing an egg at the appropriate times, right? Okay, so how would you know if this was you? Or do you still get a period? You just don't have ovulation? Is your period going to stop? Are there going to be signs and symptoms like your uterus swelling? How do we know we're not ovulating?
So this is all very dependent on the person. Some people are still having regular cycles, so they're having a regular period, but they're not ovulating and they're still shedding that lining. But then there are times where, especially with patients with PCOS, they have very irregular cycles. And so they may ovulate and then it may be a couple months before they have another cycle and things like that. And so unless you are actively tracking your cycle, it can sometimes be hard to know if you are ovulating or not. So if you're having a regular cycle and you've been trying to conceive for a certain amount of time, but you're not tracking your cycles yet, that is something where a physician is likely going to check for if you ever decide to go into the clinic. Now, if you're having irregular cycles, that can be hard to determine because you still may be ovulating here and there. But really, the easiest way to determine if you're ovulating is to track your cycle. So, with that being LH test strips and potentially progesterone strips as well. So, when you ovulate, really right before you ovulate, your LH, which is luteinizing hormone, which is the hormone that is involved in ovulation. I don't want to get too sciencey, but that hormone will surge or spike. If you ever hear people talking about, I'm surging now and all those sorts of things, it's taken like a pregnancy test. So it's like a test strip. You dip it in your urine. And unlike a pregnancy test, it will always be positive. So you will always see two lines. But as you get closer to ovulation, your LH starts to rise and that test line will start to darken. And when it gets as dark or darker than the control line, you are surging, your LH is surging, and that means that you will ovulate in the next 12 to 24, 36 hours or so. So when you get that surge, it doesn't mean you're ovulating right that second. It means you will be ovulating in the next 12 to 24 hours. It's definitely a range dependent on the person. And so that is a good positive sign that you likely are ovulating. But to confirm that ovulation, really you want to test your progesterone as well, because it should rise after your LH rises. So I don't know if any of you guys have seen some of the charts that are out there. After your LH rises, it goes back down. And then sometimes up to a week after your suspected ovulation, your progesterone will begin to rise as well, because your progesterone is rising to thicken your uterine lining to support that potential implantation of an embryo. So there's definitely some hormones that we can follow there. And there are lots of companies out there that offer LH test strips and progesterone test strips. The biggest thing is learning how to read them, because they're not always easy to read. Like I said, you will always get two lines, unlike a pregnancy test. And so determining, is this line really dark, or is it darker than the control? Those are the times where I'm like, oh my gosh, because I've taken them myself. I track my cycle literally every single month. And so it takes a little practice to read. And so some of the test strips out there have apps that accompany them to help you try to figure out whether it's positive or not. And there's lots of YouTube videos and things out there that can kind of help support you in trying to read those. But that is kind of how we are confirming ovulation at home. If you ever went to a clinic for treatment, they would confirm ovulation in those same ways, but with an ultrasound as well. So they would check LH, they'd likely check estrogen and progesterone and FSH and all those things. But then they can also see via ultrasound. So they can see when your follicle size gets really big and nice and plump, and it will likely ovulate soon. And then they can check you in a few days and they can see that follicle has shrunk, meaning the egg is no longer there. So lots of ways that we can kind of check that there. But I think most often, especially when patients are just starting to try to conceive, they're doing at-home testing. I know that was a lot.
No, that was really helpful, but I do have a couple questions. Do you ever have, or would it be possible, do we see people have an LH surge but no ovulation? Or is it possible that you don't ovulate, so you get that progesterone rise if you don't ovulate, or when you don't ovulate, you don't get that progesterone rise? How does that work? How does, I guess, anovulation impact both the LH surge and the progesterone that we would typically see rise and fall systematically?
Yeah, so there are a couple things. So if you can have an LH surge without a progesterone rise. And so I am not an expert on the specific hormones. So if
Yeah.
you want to fact check me, please do.
Yeah.
You can have an LH surge without a progesterone rise. And so in those cases, some people will say it wasn't a productive ovulation. Like your LH rose but the egg didn't actually get released to
Yeah.
trigger that progesterone rise. And then there are some people who just don't get an LH surge at all, meaning that it's possible that their ovaries aren't, they're not growing the egg to maturity, they're not getting released properly. There's a lot of places where things can go, not as hoped. The other thing that we take into consideration is FSH, which is follicle stimulating hormone. That is the hormone that tells your follicles to mature, to grow, because we are born with all the eggs we're ever going to have. And so, every month your body is recruiting a certain number of follicles, and that FSH is what is maturing them enough to where they are ready to ovulate. So there can be a lot of dysfunction in all of those hormones: FSH, LH, progesterone, and estrogen. So those are all hormones that typically, if you're in a clinical setting, they are monitoring or potentially testing to see if you've, got a deficiency somewhere, or maybe something's too high, and all of those sorts of things. So definitely, if you, what I usually tell people is there are some great charts online, and not everyone follows these charts. Don't get me wrong, but they're a good guide to start with to kind of understand when something should be rising, when something should fall, and what is somewhat normal, because everyone's cycles are a little bit different, and just because they're slightly off doesn't mean you're not ovulating appropriately, but it's a nice guide to have if you're newer to tracking your cycle.
Yeah. Okay, so when would someone seek fertility help in terms of, okay, I've been monitoring, I am having some irregular cycles, I'm, maybe not seeing that LH surge, or I'm checking my progesterone and I'm not seeing it. When is there a certain number of months? Is there, we need to try for this long? So many people say, you know, I heard that you have to try for 1 year before you seek fertility, but then I've been seeing more recent actual physicians say that's not true. You don't have to. You should come to us kind of sooner than that. So
Mhm.
what is the true answer? How do we kind of determine where we fall on that spectrum?
Mhm. Ultimately, if you are concerned, go see a doctor.
Yeah.
And I appreciate that physicians are open about it, because there are guidelines that say, hey, if you've been trying to conceive for over a year, you should seek treatment. That
Yeah.
is that is a perfectly fine guideline, and if that's what you want to follow, fine. But if you're older, or you have PCOS, or endometriosis, or something of that matter, or you only have one ovary, or your partner doesn't have the highest quality sperm, or whatever, it never hurts to seek treatment earlier. Really, the longer we wait, the lower our chances get as we age, for people who have eggs and for people who have sperm. So I am all for, like, if you are concerned, go see a doctor, especially
Yeah.
recently, because consults for a lot of fertility clinics are backed up like 6 weeks, 8 weeks. So, you are automatically going to tack on
Wow.
2 months just to wait for a consult a lot of times. So I say, if you're concerned, go for it at the bare minimum. If you've been trying to conceive for a year and either have had multiple miscarriages or haven't conceived at all, definitely go seek out a specialist.
Wow. That is a crazy wait list. Is that new since COVID? Wow. What do you
I
think
will say
that's
we
about?
have seen Yeah, so we have seen a big uptick
Wow.
since COVID, which
Yeah.
which is very weird, because in the embryology world, a lot of pioneers of the field and people who have been doing this for a long time retired, because they've been doing this for a long
Oh,
time, so they retired. But we saw an increase of patients, so it was kind of inversely, it wasn't super helpful for
yeah.
clinics. So a lot of we were having an embryology shortage, but then we were having an increase of patients. And I think a lot of it was COVID kind of grounded a lot of people, and a lot of people realized what they valued. And hey,
Hmm.
like, I want a family. I want to grow my family, or add to my family, or start a family, whatever. And so a lot of people started to try to conceive during COVID, and then realized that they were having issues. And so, right at the end of 2020 and into 2021, huge influx. At least that's what I saw personally. A lot of clinics kind of having a big boost there of patients. And I think a lot of people realize, like, it's not necessarily as easy to conceive as we thought it is. The World Health Organization, just released updated numbers. 10 years ago, 1 in 8 people suffered from infertility, and now it's 1 in 6. So it's very common. And unfortunately, I do think it will continue to rise with environmental factors and people waiting longer to have kids. I only see infertility kind of increasing, unfortunately.
Wow, really? That's harrowing. Yeah? I mean, we don't have I'm thinking about, like, in my brain, little cartoon, like, characters, and there's only 6 of them, so eventually, what do you think will happen? All babies will be kind of like lab created in IVF?
I wouldn't say all babies. It's hard to know, predict the future,
Yeah.
but I do think we will start to see, yeah, I do think we will start to see more patients making a push to preserve their fertility. So I
Yeah.
could definitely see people, young people saying, I'm not ready to have kids yet, but I know fertility is on the decline. Let me consider freezing my eggs, freezing my sperm, maybe getting a fertility workup just to see where I'm at. I mean, I've got a workup. I have no plans to have kids in the next 3 years. And I mean, being in the field, you get a little worried, but I've had a workup done. And it's just nice having that knowledge to know, hey, I may need to change my family building plans based on what my fertility health is telling me and my
Wow.
partner's fertility health is telling me. So I'm a big advocate for at any age. If you're curious about your fertility and it's something that you want in the future and you're not ready at this moment, go get an evaluation. A lot of it, thankfully, a lot of insurances are finally getting on board with,
Wow.
covering some of these things, at least diagnostic testing. So it's getting better in terms of coverage.
Okay, and what would that look like if somebody was like, "All right, I'm curious. I wanna see, what's going on inside my body fertility-wise." A, do you just call them up and say, "Hey, I'd like to have an initial consult," or how do you do that? And also, like, what can we expect from that visit?
Absolutely. So some patients get referred to fertility clinics from like their OB or their primary care. That's who they're seeing. And they're like, well, I'm not haven't been able to conceive. What do I do? And so they get a referral to a fertility specialist. But you can absolutely just call the clinic. Most clinics, you don't need a referral. We call these patients off the street, which is totally fine. Like it's not a bad thing or anything. You're more than welcome to call the clinic and schedule an appointment. And that initial appointment, you are typically meeting with your physician for the first time. And it's kind of a trial. I consider it a trial period for both people. It really depends on why you're seeking them out. If you know you are going to need treatment, I think it's a different conversation than someone who is coming in just curious about your fertility. So I'll just talk about someone who's curious about their own fertility and may not know that they have an issue. Typically, that conversation is, well, what are your goals? Are you wanting to have a family? Do you have anything at this point, any reason that you're concerned that you may not be able to have a family? Like patients who haven't even considered having a family and then they find out they have cancer and they're like, well, I don't even know if I want a family yet, but I want to have the option. What sort of options are out there? So the physician's going to talk to you about your general history and likely your fertility history. Your periods, are they regular, are they irregular, have you ever had anyone tell you had PCOS or endometriosis? Just general lifestyle questions too. Do you smoke? How often do you drink alcohol? Even into your parents, like, did your parents have any fertility issues conceiving you? And so they go into family history a little bit. And then at that point, they're likely suggesting diagnostic testing. So a very, very common one is an HSG, which I will not give the full name to because it's very long. I never pronounce it correctly. But essentially, what it is, we are testing, not we, I do not do it. The physicians are testing if your fallopian tubes are open. So the ovaries release an egg and they travel down the fallopian tube to meet the sperm in the tube. And so if your tubes are blocked or they're scarring or you've had them cut for tubal ligation, you will not be able to conceive or you'll have difficulty conceiving because that egg can't get to where it needs to go. So that's a very common test. I wouldn't say it's painless. It's uncomfortable. It's very uncomfortable. If you're a type of person, I'm all for physicians giving patients meds for IUD placements and all that sort of stuff.
Yeah.
But that's a very common one. Typically, that's coupled with blood work. So hormone testing. Like I said, they're testing your FSH, your LH, your progesterone, your estrogen. They're often testing your testosterone as well, your TSH and thyroid and all of those sorts of things. as well as doing a vaginal ultrasound to determine your antral follicle count. And so your antral follicle count coupled with your AMH, which is a blood test, can kind of give the physician an idea of your ovarian reserve, which is really important because if you have a low ovarian reserve, you've got limited time in terms of trying to conceive because you have less eggs available. If you have a normal ovarian reserve, you may not need to rush, you may be able to take your time, sort of thing. And then the other thing coupled with this, which I always mention because I think people forget, your partner. Your partner is very important in this process too. It's not just the eggs, the sperm are important. And so anyone who messages me and says, I haven't been able to conceive, what should I do? I'm absolutely gonna say you should get some diagnostic testing done. But so should your partner, because the sperm is half the process, and you would be surprised how many people think that it's not the sperm, and they are a large cause of infertility as well. And so bring your partner with you, because the amount of time I've literally seen patients go months without a semen analysis, and they spend all this time and all this money, and then their partner has no sperm. And so I'm like, we wasted some time. We could have done an analysis and then gone from there. So you should be getting all that diagnostic testing, but your partner also will likely get some blood work done, some hormone testing done, and a semen analysis. That's very important because we want to make sure they've got some swimmers.
So what kind of things can we see go funky with male hormones?
So the male side I'm not quite as familiar with, just because so much focus is on, the person who's got eggs. But testosterone is a big one because it helps produce a lot of the sperm and things like that. Varicoceles are very common, so blockages or restrictions in some of the tubules that cause morphological defects in the sperm. Age is also important for sperm as well. I know age is a big one for people who've got eggs, but sperm quality and DNA integrity decreases with age as well. So that's an important factor. Hormone wise, I think they also look at FSH, testosterone. There's another one that is slipping my mind. I cannot think of it, but there's another one that they're usually testing men for as well. But typically the semen analysis, they usually start with a semen analysis. I'm not going to lie. Most clinics don't start with blood work. They're starting with a semen analysis. And let's be honest, it's easy for them to get. It's not invasive. It's a fairly cheap test. So honestly, I think one of the most lucrative tests in diagnostic treatment for infertility is a semen analysis. It's affordable, it's quick, it's not based on your cycle, because some of these other tests like HSGs and things and blood work, patients have to come on a certain day of their cycle, versus semen analysis. If you've got 2 days abstinence, you can go to the clinic today. So I think that's such a valuable test, and it gives us so much information in relation to the price. It's a very affordable, diagnostic test.
So does that mean that on the male/semen side that hormones are not really ever too much of a concern, but it's almost always the actual semen itself, like the actual sperm itself is the problem rather than hormone? Wherein in females or the egg carrying person, it could be hormonally based like PCOS, or it could be the egg itself.
So typically with sperm, the hormones play a role in creating the sperm.
Got
So it's
it.
almost like a cascading effect. If
Yep.
their hormones are off, it will create issues in the sperm. But just because they have sperm or semen issues doesn't necessarily mean it's a hormone issue, if that makes sense. So one creates the other, but if you have an issue, it doesn't necessarily mean it's a hormone issue.
Yeah. No, that makes sense. Okay, and you mentioned scarring of the fallopian tube. What would cause that?
So a handful of things. Some of it is actually physical. And the reason I mention this because there are lots of patients who come after car accidents or other, things. And so that physical piece is bigger than you think. And so I always mention that because there are lots of people out there who end up in accidents and things and have some scarring. It can also be from STIs. So chlamydia is a big one. That causes some infertility issues, specifically fallopian tube related. Sometimes it's from prior procedures. Like if they've had endometriosis removed or fibroids or things like that, that could have created some scarring in the uterus and the tubes. And I think some people are, just born with, tubal issues, not necessarily scarring, but where they've got some damage or blockages, things like that. And so not only does the HSG kind of test for that, they call it fill and spill. So if you ever see someone with a ultrasound and it says fill and spill, and that's what they're doing. They're filling up the uterus and it spills out the side of the tubes. Yeah, so surgeries, and some people are just born with tubal issues, and it's an anatomy thing. And so they're born without a tube. I've seen people born without a tube or have had them removed for some reason or another. Oh, like I know what I was saying. Not only does the HSG tell us if the tubes are open, oftentimes they can help open them. So if there is a small blockage or narrowing somewhere because they're pushing fluid through the tubes, oftentimes that gives you a little increase of your chances for a few months after doing that HSG, because we kind of pushed some fluid through and potentially opened up some areas that were a little more narrow.
Okay. All right. And how would you know? My mind is just like reeling right now. How would you know if you were missing a tube or an ovary? Like, is that something I've literally never had an ultrasound of my belly? So I don't know if, unless I remember my pediatrician feeling my belly as a child. So maybe they were checking for it. Maybe it's something that your OB feels around for. But how would you know? Or maybe do a lot of people not know until they experience fertility problems and then they're like well into adulthood and they're like, oh, I've been missing this whole piece of my body?
Yeah, unfortunately, it is very common that a lot of people don't know because it's
Wow.
not common to do a vaginal ultrasound. So these are ultrasound probes that are placed vaginally, and that's how we're able to see the ovaries. Some of the testing, they can't see like the cavity of the uterus with an ultrasound. So sometimes they have to do other procedures to be able to see if there's fibroids and things. But a lot of people don't know. I've never had a vaginal ultrasound. I
No.
had an ultrasound when I got an IUD put in, but like I don't know if I have both my ovaries. I have no idea.
Yeah, me neither. I
Yeah. So unless
wow.
you like as a young person had like issues with your cycle, like if you had severe pain or something like that, maybe they would have found out because they did an ultrasound at the time. People who have, endometriosis and PCOS, oftentimes their cycles are filled with kind of more painful periods. And so maybe they got an ultrasound then. But for like the average person, they don't know until they try to conceive, which is something that I don't love. Like I wish it was part of a regular like pap exam or like what wellness exam. It'd be nice if they can't cost that much more to do a 5 minute vaginal. I'm telling you, it doesn't take that long to do the ultrasound part. It's like 10 minutes.
Wow. It never, ever, ever ceases to amaze me all the things that we don't know about women's health. And I know this includes men as well, but I just feel like women's health in particularly has been truly
Mm-hmm.
neglected. And it is just unreal to me to think that I guess people who are much older than us, like literally 70, 80, 90s year old, they were well out of their childbearing years by the time IVF got super popular. They may never have had children because the access to this information wasn't available, and they're like the chance is gone. I guess it shocks me that the opportunity, we've always had women around and it has been so neglected that we're in 2023 and we still don't know so much about the female body. That it blows my mind every time. I have this reaction every single
Yeah.
time. I'm like, wow. And it just feels like a new, like, you know?
Yeah, and I completely agree. Like I knew very little about my body until I got in this field. And I was like, I am college educated and I had parents and friends and family who who went to school and have had kids and all these things, and I'm just now finding this out at 23 years old. Like, that
Mhm.
is crazy to me. And so just the fact that I've been exposed to it and know it, that just like tells me how little like the average person really knows. And I'm a huge advocate for
Mhm.
like comprehensive sex education
Mhm.
and reproductive health knowledge. Like, all this is so important. And I grew up in a very small town. I
Mhm.
live here now. I moved back. But we had no sex education. I
Yeah.
mean, there wasn't even like, they were like, here's a tampon, here's a pad, good luck. And I was like,
What is
okay.
this?
And it's just, it's not talked about enough. And the places where it is talked about, it's in an abstinence standpoint or a fear mongering standpoint, and not really, teaching people, how does this really work? And when do I know something is wrong? Or when should I see a doctor? It's not framed that way. And so your whole life, you're like, trying not to get pregnant. I can't get pregnant. I'm too young. I don't want to be a teen mom, blah, blah, blah. And then when you're ready to get pregnant, you don't even know what to do. You don't even know how to track your cycle. You don't know what's normal, or, how do I know if I'm ovulating? Because it's not something that's taught to you. And if fertility is truly on the decline, which I truly believe it is based on the research that I've seen, and it's going to continue to, decline, why are we not having that conversation? Why are we not saying, I'm not saying we should, having a bunch of teenagers having kids, but having a basic understanding of how it works, I think is beneficial. At least when you get to the high school and college level, because I get people are like, well, it's not an appropriate conversation. And there are some scientific things that are, concepts that are harder to grasp. But I think a 16-year-old, if they're having kids at 16, they can understand how it happens, you know?
Yeah. Well, if you have your period at 16, you deserve to know what's happening in your body. And I think that's where I land on the topic, is that it's not about what you do or don't think kids should or shouldn't know. It's that something is happening within another human's body and they deserve to understand what that is.
Mhm.
Um and then as your parent, you can teach them what to do with that information, but that basic anatomy, that basic understanding of how to work with your hormones. I mean, I just think about how many lives would have been changed, how many people would have made different decisions one way or the other. It doesn't matter. Earlier on, had they just had the information, it literally is the same thing as the old ladies that know nothing about their body, but they probably could have had children had women's health been prioritized. Because 100 years, we did have
Mhm.
medicine. It's not like we were still, you know, going to people's home and like sprinkling herbs on like broken feet and stuff. Like, medicine existed 100 years ago. We
Mhm.
could have been prioritizing women's health to just have more advanced medicine in 2023, I think. And
Mhm.
it's sad to
Yep.
me, it shocks me every time, but it also, once all of that settles, I just get like really frustrated, because it is frustrating. It's very
Mhm.
frustrating that there are literally adults out there that don't know what is going on with their body. I mean, children too, like you say, 14, 15-year-old old.
Mhm.
If you are old enough to have a period, to get an erection, you need to understand what is happening in your body. And then I think it's up to families to teach
Yep.
their children what to do with that. But just
I
they
agree.
deserve to
I
know.
agree. And that's why I think if you are curious about your own fertility or your own family building potential, I don't care how old you are. Go see
Yeah.
a doctor. Go get diagnostic testing. Start tracking your cycle if you're curious. I'm not trying to conceive right now,
Mhm.
but I've been
Mhm.
off of birth control for 3 years and learned so much about my cycle and about how my mood changes and about how my energy changes in that cycle in that month. And so I think it's so important, regardless of your age, if that's something that you want to know, make it a priority. Advocate for yourself at the doctor. Hey, something isn't right. Or, hey, I'm really curious about this. Maybe my mom or my aunt had issues getting pregnant, and I'm not trying to conceive at this point, but I really want to know, because it changed, like you were saying, it changes your decision. It can change your decision, because it did for me. I wasn't ready to have kids, but I got my fertility workup done and my AMH is fairly low. So I can't. I have the fertility, the ovarian reserve of someone who is 10 to 15 years older than me,
Wow.
and so that changes plans.
Yeah.
That changes how we decide to plan the next 5 or 10 years of our life. And so a lot of people don't instead of me waiting 5 or 10 years and then finding out that we can't have children, or it's more difficult for us to have kids and we do IVF, I know now I can make a decision on my healthcare now. And so I think that's the important piece too. It doesn't necessarily have to change your plans, but you have the option to do something about it.
Mhm,
If it potentially could change your plans, it's up to you. You have that knowledge. You have that knowledge to make a decision.
Yeah, it makes me think about all the people that are stuck in, like I say, we just started fertility treatment support, and every single call, somebody says, we just wish we would have known, right? There's someone in that couple that says, if we had known, we would have made decisions different. And that is one of my biggest takeaways, is that within fertility spaces, in general, there is just not enough access. People do not know what is going on in their bodies, and there is nobody out there teaching this. And the internet has made it better, but it has also muddled it with information that is maybe not always right. I think a lot of people are really good
Mhm.
intentioned on the internet, but sometimes, and fertility specifically, it is as individual as your thumbprint. You need to know what is going on in your body before you go around messing with things like hormones and
Mhm.
supplements and like big, big lifestyle changes, like diet things, like removing whole food groups out of your diet. I've seen people go to extremes. And so I just want to caution you that make sure you're getting information specifically to you. You're working with a provider who is on board with your goals and on board with your timeline and
Mhm.
honors your preferences and really values kind of what you want out of your fertility, right? They are an important part, but they shouldn't be the driver. You and your partner should be the driver. You by yourself should be the driver
Mhm.
of what goes on
Mhm.
with your fertility. I mean, I think not a lot of people have that permission. I think a lot of people come to fertility treatments and they feel very, gosh, a lot of things. Very sad. There's some guilt. There is embarrassment. There's shame. There is that regret of,
Mhm.
I wish I would have known. I wish I would have done things differently. There's so many things. And so they almost feel, regardless of if they are made to feel this way by their medical staff, by their IVF staff, but there is this sense of, I need to just do what I'm told so I can get what I want, which is a baby. And I want you to know
Mhm.
and have permission, a good IVF doctor will work with you. They want to be collaborative, right? So
Mhm.
find somebody who
Mhm.
does actually value you in that way and wants to be a team with you, because it is really what that's about.
Yep, I think that is absolutely fantastic advice. And what I'd love to add to that is, regardless of if you've gone to a fertility clinic before or not, you've likely gone to some sort of medical professional.
Yeah.
And what sorts of things did you like about that experience? And what sorts of things did you not like? And what are some of the things that you value in your life, in a healthcare setting in general? Take those things with you when you go to a clinic. You don't have to know anything about fertility, but just your experiences with healthcare professionals in the past can help you decide, is this a physician that is going to work for me? Is this a
Yeah.
clinic that I want to get care with? Because infertility is a hard journey. It's expensive, it's time consuming, it's very stressful. Like you said, there's a lot of guilt, there's a lot of conflict potentially between relationships with you and other family members, with you and friends. And so it's already going to be a difficult journey. You want to make sure your team, not just your physician, the whole team, is someone that you want to work with. And
Yeah.
so, take those things that you value. I'm literally getting like chill bumps because I think this is so important. Take those values and those things that you didn't like about other, maybe their financial team wasn't easy to work with and you don't want to deal with that again. Take those things into that initial consultation, and take note of how you feel after that
Hmm.
conversation and consultation with the physician. I'm very much into like gut feeling sort of thing. Like, I'm a very scientific person, but I also believe that potential spiritual or emotional feeling is very important in the process, because you spend a lot of time there. If you're getting treatment, you're there every other day. You're talking to the financial team often. And so it's not like a one-off when you're getting a pap smear and you go, every 3 years. You're seeing them a lot. And so it's a very different relationship than you would potentially have with other sorts of physicians. So I like for people to keep that in mind. And I actually have a free guide to choosing a clinic on my website. I think it's got some great points. It talks about the physician, it talks about the cost, it talks about the lab, which is a very important part because obviously I'm part of the lab. It talks about all of those things and just gives you some points to think about before you go to that consultation, because there is some prep work you want to have done beforehand. So you go in and have a productive conversation with the physician and potentially other staff that's there. So that's really my 2 cents, because I've had so many patients be like, say the same thing. I wish I'd known this, or I wish I'd done a little more research, or talk to someone else. And the social media piece, like you said, that misinformation is killer for people who are so desperate for any sort of information, and desperate for that child or for that pregnancy. And so really get good at determining what's, good information and what's bad information. And keep in mind that we will never, anyone on the internet, unless they're your actual physician, because I know that does happen, we will never know you better than your physician who sees you. And so while we can provide knowledge and things for you to take back to your physician, we're never going to know you like someone that your actual provider would. So I never claim to be a doctor, and I try to keep things very general, but I hope that I give and provide enough knowledge for patients to be like, my doctor never mentioned that. Maybe I should ask them about it. Or, I saw this particular thing and I thought it may be relevant to me. Let me take it back to my doctor. The point is, take it back to your doctor.
Yeah.
You can't just take the word for, and really, even the actual physicians that I have met that are on the internet that are actual physicians, take it back to your personal physician because they know you the best.
Absolutely. We will link that freebie. And here is one of my hottest tips for finding a physician that you like. When you call to get an appointment, whether you are calling for the first time or you're calling to change facilities and where you get your procedures done and see your provider, ask the person who is making the appointment, say, I'm looking for a couple of things in a provider. Can I share with you what those are and get your opinion on who I should see? Those people who are making those schedules, and it's usually the front desk ladies who are also checking you out and greeting you. You guys, they're going to get to know you. They love to know who you are as a human. And also they know their doctors. IVF practices are, well, not all of them, but dare I say the good ones, they are very different than the hospital system. They're much more like a family than they are a hospital. And so it's going to be a different experience. Most IVF clinics are making you feel super loved and like they are right there with you. And it's not like they're right there with you. They really are cheering you on. They really are right there beside you. You feel loved and seen and supported. When you go to the hospital, it ain't that way. But that's another story for another day. What I'm trying to tell you is everyone at your IVF clinic cares about you and they're going to want to get to know you just like they get to know and love each other. So ask the person making that appointment, who do you think I should see if I'm looking for a doctor that X, Y, and Z? And they will be like, oh my gosh, I've got the perfect doctor for you. And they can see you in, well, I guess 8 weeks. Well, they can see you in 8 weeks now, but that is those ladies are, or those people up front, not always women, gold mines of information. They know so much stuff. Use them because they love you too. IVF clinics are,
I think
they're fun.
Great advice, because the clinic that I worked at had 2 fantastic physicians, but their personalities were so different. One was very type A. They were very on top of things. Potentially came off a little cold, but it was because they were very, put together and they never missed a beat. And then we had a physician who was also fantastic, but they were more lovey and lovey-dovey and huggy, and so it's very interesting, because I think that's such a great idea, because the front desk people that I worked at my last clinic knew those physicians like the back of their hand. So if I had called and said, hey, I really want a physician that is on their shit and very type A and is always going to be right on time, they're going to say, hey, I have the physician for you. Or if you say, I need that physician that's going to hold my hand and really be more emotionally available for me. We've got that too. I think that's such fantastic advice. I love it.
It really works well. It's something that I got to be honest, there's like pulled it out of a hat one day and was like, try asking the ladies up front when you call to make your appointment who they suggest. And I got really great feedback. They were like, oh my God, I know what doctor you need. And they ended up loving their doctor. And then I tried it again. And that person also loved their doctor, had a great experience. And I know there's no, or maybe there is, I'm not aware of it. I've never looked into this, but I'm not saying this from an evidence-based place. I am saying this anecdotally, and because it's just something I have seen in my own very, very, very limited and short practice with fertility support. But if you love your doctor, I think it makes the IVF process a little easier. And I always tend to think those people are more successful. And I think it's because they're relaxed and they feel safe and they like trust the people working on them. And so I think it matters if you love and trust your doctor. It does. It matters.
I think the trust part is very
Mhm.
important because you may come to your doctor with an idea that's a little out of the box, and you have to
Yeah.
feel comfortable enough to approach them with that idea. And it may be a fantastic idea. Your doctor may say, "Oh my God, I don't know why I didn't think about that. Let's try it out." But if you don't have that trust to approach them, then it feels very much like a factory, and you don't feel like you're really being seen or heard as a patient, or feel like your concerns are really taken care of. And that's so important,
Yeah.
especially in my experience. I find that this journey is so, so personal and very emotional. And physicians have to be aware of that and be willing to hold you up at times.
Yeah. Absolutely. Aw, this has been such a like good conversation, a fun conversation, informative. This has been so many things.
Yeah, and I literally have like days worth of stuff to continue talking about. I could talk about this forever because we haven't even gotten into we're just at the consultation and potentially some diagnostic testing. We haven't even gotten into any treatment yet. But I think that's the place to start, is that consultation and really starting to take note. And the other thing I'll mention is don't be afraid to get multiple consultations. I know sometimes the financial piece can be a barrier to that, or your
Yep.
location. If you're rural, there may only be one clinic. But if you have the means and you have the location where there are multiple options, get multiple consultations. This is, like I said, you're going to be spending a lot of time there. You're going to be spending a lot of money there. A lot of emotions are going into this. So, you want to make sure that you're feeling comfortable where you're at. And so I'm all for patients getting second opinions, another consultation. I'm all for it. And your
Yeah.
physician should be too. If they're, that's in my guide. If they're like giving you some attitude about getting a second opinion, that's a problem, in my opinion.
Bye bye. Gotta go. Oh,
They
okay.
should
So
be wanting to work with other providers.
yeah, absolutely. That collaborative care goes beyond just you and your provider. You want a provider that's also, collaborative with other practitioners because a lot of times it can be multi-layered. You're going to need a couple of practitioners working on your case. And that's totally okay. But you want a provider that's welcoming to um, that type of environment. Okay, I do have one final question, and this is just something that I'm curious about. Why would someone need to abstain from sex, or I guess ejaculation is probably what matters, for 2 days before coming in to give a semen sample?
Yes, I love that you caught on to that. Yeah. So most clinics will say that you want to have at least 2 days of abstinence, but no more than 5. And that is because it takes a certain, okay. So if you're below that abstinence period, say you just had intercourse or you ejaculated less than 24 hours before your sample, we're going to see lower volume. We're going to see lower counts in general. And so it's really just a way to standard a normal range so that we can easily. So the way that WHO, I'm like going all on a tangent, but I have to give a little backstory to make this make sense. The way that WHO, World Health Organization, determines what's normal and what's abnormal is by looking at thousands of samples across the world. And so if we don't have that standardized range of when they're going to look at the samples to determine what's normal and what's not, then that data isn't as conclusive, because we've got
Yep.
someone who's got a month abstinence, we've got someone who's 24 hours abstinence. And so it's a way for us to standardize and put you in a range of normal or abnormal. And that sounds so bad to say normal, put you in a range, but that's kind of what we're looking at. We're comparing your values to what WHO has said is normal and abnormal based on that abstinence period. So we want you to follow that abstinence period because we're comparing it to their numbers that were created using that same abstinence period. I think that's the best way to explain it. So, and what we see in the lab, like I said, when it's less than 2 days, we see lower volumes. We typically see lower count, but we see a little bit higher motility. If it's after 5 days, we usually see lower motility because some of that sperm has died or lost motilities because it's been sitting in there for a while. We're more likely to see like gel clumps, which are not necessarily an issue, but we want to make sure that our range is in the same range as what we're comparing your values to, essentially. And so what a lot of patients are very like, dude, don't, some say 2 whole days, that's so long. And some say, well, it's been like a month, so I guess I gotta, ejaculate in the next day, so I'm ready for my collection. So I see all sorts of things, and that's another key piece to trying to conceive. Your physician is going to talk to you about your sexual health. They want to make sure, are you having pain with intercourse? Are you having erectile dysfunction issues? How often are you having intercourse? Because if you're having intercourse once a month, that's not enough for you to get pregnant. And they may just say, hey, we want you to up having intercourse, or maybe, hey, we're having some, mental health intimacy issues. And so that's why we haven't had intercourse. Let's go talk to a sex therapist and see if we can work that out first before we do any medical treatment, because it could just be an intimacy thing and we're just not having intercourse, and that's why we're not getting pregnant. So lots of aspects. You can look at it from so many directions, but I think that's a really funny question about the abstinence period, because it's usually something that people are like, oh, I didn't think about that.
I didn't think about it. And I also didn't know it. And I just wondered why. Because I did know that, I know about that refractory period, but it's not 48 hours, which is why I was like, what is going on here?
Yeah. And there's another key takeaway is, sperm typically takes 72 to 73 days to go from immature sperm cell to fully mature and swimming sperm. And so when physicians suggest making any sort of lifestyle changes or adding any sort of supplementation or things like that, we tell patients come back in 3 months, because it's not going to work right away. It takes that long if you're starting a new medication now, it's just affecting the sperm that are stem cells now, that are immature sperm. And so we need to, give them time to mature. And so we tell them to come back in 3 months. And I did not mean to say stem cells. They are not stem cells. They are immature sperm. So I misspoke on that. So I want to make sure I made that clear.
Nice. Cool. Thank you for that. Okay, this has been such an amazing conversation. Oh my gosh, I have learned so much. I already felt really kind of in control of my fertility, but as always, there's more to learn, and I never considered going to have a workup kind of before I was ready to have kids. So that's a really interesting perspective for people to consider. Is it's just a deeper look into your fertility, what's going on in that moment. And, will you stay on the trajectory that you have you have yourself kind of on right now, have always envisioned for yourself, have always planned, or will you pivot based on what you find in that consultation?
Yeah, you never know. So it's great to have the knowledge, for sure.
It is. At least, where can people find you? What is your Instagram? And also, what is your website?
Yeah, I'm on Instagram, TikTok, and Facebook, although I don't post on Facebook super often. It's all at Alease, the embryologist. So website, TikTok, Instagram, Facebook, at Alease, the embryologist.
Nice. I love it. Elise, thank you so much for being here with me
Yeah.
today. And to all of our listeners, thanks for hanging out with us, you guys. It's always a great time. This conversation was extra fun to me because I knew nothing coming into this conversation. And now leaving, I actually feel pretty solid on the information. I feel like I maybe could regurgitate this to someone else and be able to teach them just a little bit of their options of what they can do in order to learn more about their fertility, maybe arm them with some questions of what they can ask their provider, give them some tests that they might be able to explore and ask if that's appropriate for them based on their goals and their finding of that consultation. So you guys, I hope that you had a fun time listening. I will see you next week. Until then, bye. Thanks for joining us. I'll see you next time on the Birth Lounge podcast. Until then, head over to Instagram and find us at Tranquility by HeHe and give us a follow. You can also check us out at thebirthlounge.com.